Okay. Good afternoon, ladies and gentlemen. This is a real pleasure to take part in this new edition of Women in Paramount Gastrointestinal Endoscopy, and I thank Professor Nada and Professor Shima a lot for this opportunity. The goal of my presentation is to explain the tools of EUS, echo-endoscopy. What do we need when we start an exam to perform an EUS under the best conditions? The best condition starts with a proper setup. As you can see on the picture taken in our unit, the patient is positioned in a left lateral decubitus position. This is not only the safest position for non-intubated patients, but also a position that allows all analysis from a wall lesion to a biliopancreatic anatomy, including the analysis of the extrahepatic biliary tree. Secondly, always use a balloon. The balloon is very helpful to stabilize your scope, and this is very useful also to analyze a wall lesion, to define the development layer of a submucosal lesion, or to define the local staging of a tumor. And sometimes the balloon will be the only way to analyze or to biopsy a lesion in the isthmus of the pancreas. For that, we start with the probe on the second duodenum. We inflate the balloon a lot and we perform a withdrawal technique with a complete traction withdrawal till 50 centimeters of the dental arches, and we are able to discover a lesion in the isthmus of the pancreas or to biopsy through the pylorus a lesion in the isthmus. And then don't forget the irrigation pump. By irrigating the digestive tract, we create an artificial separation of the layers, which make it easier to analyze. As you may know, there are two types of scopes with different characteristics. The radial scope allows a 360 degrees view in a CT scan mode, as you can see on the top right picture. This is very useful to study a wall lesion or circumferential lesions. But this scope has two downsides. The first one, there is no operative channel, so this scope is only for diagnosis. And the second downside is to analyze the isthmus of the pancreas, in particular for men, but for that we can use the inflated balloon technique. The second scope is the linear scope. The anatomy is visualized along the axis of the scope, as you can see on the bottom right picture. There is an operative channel, so this is useful to diagnose and to perform therapeutical procedures. The downside is to determine wall lesion or circumferential lesion. When we work in a referral center dedicated to therapeutic procedures, we use linear one, and if we are in an expert center for rare disease or proctology, for example, the scope, the most relevant scope will be the radial one. Biopsy is a frequent indication to perform EUS, and now when we do a biopsy we need a lot of tissue because the histopathologist need to define if the lesion is a cancer or not. Then he has to determine the origin of the lesion, and he has to define the complete tumor profile in a theranostic approach. That is to say, he has to diagnose, we have to diagnose, and we have to treat a lesion. And most of all, the biopsy must avoid wrong diagnosis, wrong treatment, or unnecessary surgeries for non-tumoral lesion, for example. So to successfully perform a biopsy of a solid lesion, the basic criteria are as follows. Always perform two passes in two different areas. Always think about the fanning technique, that is to say changing the axis of your biopsy in over 20 movements. Then we no longer perform cytology, we only do histology, and the only fixative medium is formalin, nothing else. Finally, don't forget to perform Mohs evaluation to check the quality and the quantity of your sample. You may know that in some countries the pathologist is in the operative room to perform a ROSE evaluation, rapid on-site evaluation, to guide the gastroenterologist to do the biopsy. In France, we don't do this technique. We don't do ROSE, we only do MOSE. But when we do MOSE, we can check, as I give you an example, in fact, of a biopsy I performed last week. But when I do MOSE assessment of my biopsy, I'm pretty sure that the pathologist will be able to define the diagnostic. Which needle can we use? I selected this study presented in the last ESGE to answer the question. In this study, Sedic and collaborators compared 3 needles, the 22 gauge FNA, 22 gauge new generation FNB, and the 19 gauge FNM. They always performed 2 passes, systematic fanning technique, and MOSE assessment. And they showed that the best needle was the 22 gauge new generation FNB with an efficacy of 88%, whatever the size of the lesion and whatever the location of the lesion. You have 3 examples of the new generation FNB needle. Few more tips to increase the quality of your biopsy. For vascular lesion, the 22 gauge FNA is still the recommended needle. And to do those biopsy, we perform slow pull to avoid red blood cells contamination. Then if you have a very strong lesion, we can increase the aspiration in the syringe to increase the quality of the sample. Shorten the needle sheath will reduce the gap between your probe and the wall, and it will increase the strength of your biopsy in the lesion. Then, in the same idea, a short removal of the stylet will increase the penetration of the needle in the lesion. And finally, don't forget the door knocking method, in particular for the new generation FNB. With this needle, we should hear the sound of the handle hitting the sheath. That means we increase the penetration speed of the needle into the lesion, and we will increase the quality of the biopsy. Finally, a few words about contrast. For contrast, don't forget to put the mechanical index between 0.2 and 0.4 and the focus point on the lowest pole of your lesion. To make it short, if there is if the area is avascular, this is not a good area to do the biopsy because this is probably fibrosis or necrosis area. The hypoenhanced area is the best area to do your biopsy. I give you an example in the top picture. There will be probably tumor on that area. Iso-enhancement is often an inflammatory area, and I give you an example on the bottom right picture. And hyper-enhanced areas are often vascular lesion and often NET. In clinical practice, we recommend to use contrast for difficult lesion or if we redo biopsy, for example. I thank you for your attention and